To be, I'm supposed to do this ACL talk now, but he has to go. So there we go. So this is we just want to talk about some current concept of knee replacements, and we heard a lot from Axel how to manage patient, non-operatively. So now we're going to talk about what is the innovation in surgery, and later on we're going to talk a little bit about what else can we do, and from the patient perspective, is there anything else we can do? Right, so again, similar slide, you've probably seen this before, is about outcome, innovation and rehab. And again, we're looking at the National Joint Registry, as what we have done this morning, but as I promised you, I'm going to show you the knee ones, and you can see this time our average patient is now obese instead of overweight. So it is quite important message from the Joint Registry telling us who we're operating on. And I believe the CCG actually putting a cap on BMI of 35. But if your average is 31, I don't know, most people will not fit the criteria, which is crazy, huh? So now, we saw this graph earlier on this morning. This is one for the knees instead of the hips. So you can see, that, again, it's the same coding. So the purple means that they are, doing a little bit better. And then the blue, that means they do much better. You see, we're still doing we're still doing good with a knee replacement, but not as good compared to a hip replacement. So, it's a common saying within orthopedic surgeons that 8 out of 10 people do well, 2 out of 10 doesn't do very well, which is represented by this graph, and this graph is shown by 2 million patients that we operated on. So it is something that worth considering. You don't want to be that 2 out of the 10. So again, we talk about what scores that we take. This morning we talk about hips, we've got a specific type of scores, but on knees we got a different type of score. We got the Lystrom score, which is measuring how active people are. It's more for soft tissue. And then we got the Oxford knee score is for pain, and then we got same again the visual analog scale and the forgotten joint score. Again, this will provide us a bit more of an objective measure of how how we treat patient, and when they come back, how much have they actually got better. Again, same thing. That go with all across. As I say, upper limb, lower limb, any surgery, it's the same thing. Patient factor, implant factor, and surgeon's factor. And we talk about the patient factor, we talk about the implant factors earlier on. Now the surgeons, again we talk about we're not all the same. So again, same slide, the whole process, but this time it's more on the knee and the hip. So it's similar but slightly different. So tourniquet is one thing I want to talk about. Most surgeons, when they operate the knee, they put a tourniquet on. Now to me, it makes absolutely no sense. A tourniquet, when we're doing, the reason that we use a tourniquet because traditionally, long time ago, people were doing knee surgery. It's a good idea to put this on, so therefore it will be completely bloodless, so patients don't lose any blood during the operation, so they don't need a blood transfusion. Okay, that's a good concept behind it. But then actually, what are we doing with that tourniquet? We blow this tourniquet up to 300 millimeter of mercury, which is really hard, hard pressing around your muscle, all the way around your muscle, and we pressing this for about an hour and a half, and then after that we expect patient to walk. That's crazy. So it is, but it is something very common. Most orthopedic surgeons, they tend to like to use a tourniquet because they got taught that way, and that's how it is. And if you challenge them and say, "Oh no, they bleed less," but actually, if you don't use a tourniquet for the operation, patients don't bleed. They don't bleed a lot. They don't need blood transfusion. They will bleed a little bit more than compared with if you don't use a tourniquet. But in terms of rehabilitation, immediately post-op, it make a huge difference. If you imagine, you haven't got your muscle being crushed for that long. So we have asked you to stand up and walk. You say, yeah, you will. You can. But if your muscle been crushed for so long, you probably don't want to. And people may argue that, okay, after 3 months they're all the same. Yes, I agree with you, but for the first 2 weeks they're not the same, and that's very important. So tourniquet, so I don't use tourniquet. There's different ways and different methods to negotiate around it, and again, it gives a very good result too. The other thing is about alignment. So we look at things slightly differently on the knee than the hip. The hip is a ball and socket joint. We went through a little bit of how we plan the hip replacement earlier on. So for the knee replacement, we do the same thing. We plan. So how do we plan? We don't just focus on the knee and knee alone. We need to look at the hip and the ankle. It connected to the whole body, surprisingly. So we want to look at mechanical axis. So which means that when you stand up, you draw a straight line down. So where your weight falls. So this is the orange line, which is the mechanical axis, and then we got the anatomical axis. So our bone is not completely straight, so they point slightly one way or the other, so varus or valgus. So based on that, so if you look at the joint line, so that blue line there, the natural joint line for normal anatomy is about 3 degrees, tilted. Traditionally, we taught to put everything straight, flat, dead on, 90 degrees. So to me, that doesn't really make too much sense. If we build to have a 3 degree of varus and we cut them and put them straight, surely it's not the same. So how can so that's something that we need to look into. Why did we do it like that before? Because it's much easier to cut straight than cut slightly wonky. But there are methods and there's ways that we can do it now. There's technology available that help us to cut at that 3 degrees. So that's where the robots come in. So we got robots to help us to how to improve our balancing with the knee, how we can actually get that knee replacement in kinematically perfectly. And so one of the robots that is really good is this Navio robot, which allow you to balance the knee all the range through. And again, we talk about the black ceramic, so something that the technology is available in the knee. So with the black ceramic, we talked about the benefit of it earlier on. In the knee, actually, it's much more important than in the hip, because if you imagine on the hip, it's just the ball that we have to use at the top. So if you think it's the ball, the material is quite thick, so they're not shattered that easily. On the knee, it's quite a big, large surface area. And so if this is just big by purely ceramic, it will get smashed, and we don't want that. So this metal ceramic is a great option. This is just some intra-operative pictures of how we do using the computer, and how we balance and how we change the flexion and extension gap, and how we actually do it intraoperatively, plan it. If we cut there, what would actually happen? So we actually do it live before we cut. So it's something that we can use to help us. So I talked about the black ceramic already. So this is just a cross section to show you a knee replacement. Again, same outcome. Patient want the same thing. Whether it's hip joint, knee joint. That's what they want. They want a pain-free, forgotten joint that lasts forever, and they don't want to see me again. That's what they want. To achieve that, that's how we're going to do it. Shared decision making. We talked about this earlier on. The next thing I want to talk about is very important. Is the treatment pathway for the knee. Now, in your handbook, if you go into the knee section, in there's a treatment pathway that we have developed. And as a surgeon, I'm promoting non-surgical intervention. I don't think surgery is for everybody. I don't think surgery is the first line. Now, it's very difficult in terms of traditional treatment. How do we treat osteoarthritis? Because patients got pain. Axel have talked about using painkillers. They talk about using different methods, using injection to help. But then I don't think the CCG or the government have not allowed some of these interventions to be used in the NHS. But these are very, very useful intervention. Like hyaluronic acid, which I'm going to talk about later on, PRP and cell therapy. These are very, very useful. And it will stop the patient having big, huge chunk of metal inside them. As I talked to you guys earlier about what a big what a knee replacement really is or hip replacement is a glorified splinter that we jam it into the bone. So we don't really want that for our patient. We want to keep things biological. And if you, as a patient, if you can get away with a tablet, you will take a tablet. And then you can get away with needle, have an injection, you have a needle. Only if you really can't help it, you have surgery, right? So this is the pathway that we have developed with the OA knee group. That it's different method, different modality we should follow, and different way that we you can see it's the knee OA treatment cycle. So within that cycle, it's very important. We need to offload that patient. We need to give them physiotherapy. We need to manage the pain. We need to give them injection, whether that is steroid or not. A bit controversial about that. And you can there's more stuff about the steroid on the cell therapy section, but I'll go through that later on the next section. But what I want to talk about is this knee brace here, which is quite amazing. We have been using that for 15 years. We have got great data on this knee brace. So I want to share this next 2 slides with you. So this is a short-term effect, wearing this unloaded knee brace compared to no treatment at all. So there are patients that are on the waiting list waiting for a total knee replacement. In Wales, where I worked before, their waiting list is up to 2 years, 3 years. So not everybody can wait that long. They have to go back to work. They got their livelihood at stake. So we say, okay, we got this knee brace. Would you like to try it? So they try this knee brace on, and we follow them up for the last 10 years and see how they get on. The interesting thing is half of those patients initially were on the waiting list, they don't actually progress to an operation. So we actually have saved 50% of the operation, which is quite amazing, you know. So then we do some about economic study, health economic study, to look at what is the economic impact, you know, with this brace compared to someone that, you know, going for knee surgery, you know. So this is comparing with giving a brace to no treatment. No treatment is free, okay? So a brace costs money. So we have figured out that at 8 months, our money cost for treatment, we're actually saving society £10,000 because patient actually gone back to work, you know, giving, you know, paying the taxes and, you know, instead of being off sick. So, you know, we have actually doing society good. And if you look at, you know, the treatment, what NICE recommend, you know, the threshold is £20,000 to £30,000 per quality life year. You know, we are much less. The next slide is that the long-term effect, you know, so we're comparing a brace versus a total knee replacement. If someone have a total knee replacement, we assume that they got 100% success rate, they do absolutely amazingly well, and we assume that this knee replacement lasts 20 years. We know that knee replacement doesn't last 20 years on a young patient, but we assume, you know, we want to compare to really, really harsh condition. So even with that comparison, with a brace to a total knee replacement, you know, that the brace still end up cheaper, you know, £6,000 cheaper, you know, that is 8 years down the line. And patient, again, did not need to have surgery. So, you know, you're saving a lot of potential complication. You know, a knee replacement maximum lasts about 10 years on someone who's under 50. And, you know, if you have complication, a revision knee surgery is £25,000. So, you know, there's a lot of, you know, things on there. These are the publications that, you know, we have published in the BMJ to talk about, you know, this economic study, if you are interested to read more about it. So that's just the knee brace. So the next thing I want to do is I want to invite one of my patients, you know, come along and have a chat. Paul, would you mind come up about using the unloaded brace? So Paul came and see me approximately 7 months ago now, isn't it, roughly? September time. And so free to see me initially.
Initially, it was last summer. We was in France and we was walking around various historic sites, castles and things up and down the steps. And after a week, I couldn't walk anymore really. I was having to sit. My knee had swollen up and I couldn't really do much of anything at all, other than rest it. I'd hurt it. It had given me a bit of a niggling pain for a while, but I twisted it 2 years ago skiing. And I've always been active: football, taekwondo, cycling. I was in the fire service for 30 years, so I'd always been active. But then, since I retired and my knee had given me problems, I've obviously put on a lot of weight as well, which I'm now trying to reduce. And that was sort of the problem really come last September.
So what treatment option have you had so far? Before you see me, what did you have?
Before I came to see you, I'd been getting from the chemist the gels, the different types of gels, and rubbing them in, and so that was really it. Really, other than some painkillers and rubbing the gel in.
Sure.
Yeah.
So would you think that your knee was really affecting your lifestyle? And stopping you?
Yeah, it is. It really was. Yeah, and I knew my skiing days would probably be over, which was a big upset because I've always skied. So
we talk about then when you come and see me, we talk about different treatment options.
Yep.
Then we talk about this unloading brace.
Yep.
So you're brave enough to give it a go.
Yep.
And so how do you think you've been using that brace since
Yeah, since I got it after I came through for the MRI scan, then I had the brace fitted in September. I put it on first thing in the morning. I wear it all day. Take it off last thing at night. And it's been absolutely amazing. I cannot believe how good it's been. We went with the family. We all went skiing again in December. I obviously didn't ski, but I went on the holiday, and all the family skied. And I spent the whole 10 days. I had some walking ski pole sticks, and I was walking up and down the mountains all day, every day for 10 days. And in the August before in France, I couldn't walk around just in the summertime in my shorts and things. Amazing difference. And the pains. I'm not on any painkillers. I'm not rubbing any gels in. I literally just strap it on in the morning, take it off at night, and that's it.
So it's a really, really good method of non-surgical management in terms of the knee pain. And otherwise, perhaps someone may offer you a total knee replacement. I don't know, but in the moment, if this is a great option and it's off the shelf, isn't it? Pretty much, and and make it readily available and help patients and change your life pretty much instantly. And so there you go. So thank you very much for sharing the experience.
That's fine.
Thank you.